Dr. Sahil Chopra, welcome to the Vagina Doctor podcast. How are you?
I'm doing wonderful. So good to see you both.
Great. So, did you go to medical school when you were 10? You have 4 specialties, 4 qualifications, board certifications: internist, pulmonologist, intensivist, sleep specialist. Well, that's the one we're going to talk about mainly today, but what a lot of training, what a lot of experience. You're a very bright
Yeah,
man
it's been a journey. Um,
and in great places too. I mean, you went to Harvard, Loma, UCLA. You've got quite a story there.
How did you get to sleep? From all of that to sleep?
you know, um, I think there's a couple of things that happened around the same time during my pulmonary critical care fellowship.
Mm-hmm.
The first was I myself was really sleep deprived.
Yeah.
Uh, you know, i- Intensive care medicine is a pretty intense specialty, as you would imagine. Like you're working between days and nights and long hours, and um, this was a time where I had a young family. Like we had 2 kids when I was in fellowship, so I was sleep deprived and working a lot. So like this idea of burning both ends of the candle was very real to me. And around that same time, I had read this book called Why We Sleep by Matt Walker. Um, so like I became really interested in sleep health, generally speaking. Um, and then the other thing that happened was in our pulmonary clinic, we see patients who have a sleep disorder called sleep apnea.
Yeah.
And it would take patients like months to get in, months to get a sleep study, months to get started on treatment. And like these 3 things sort of converged in a way where I knew how important sleep was. I myself was suffering from chronic sleep deprivation. And now you see someone who's like hypoxic or like very low oxygen levels the entire night for extended periods of time. And I just kind of got frustrated with like why the system was so broken. And I thought the field was super interesting. And I decided to sort of jump all in to do a sleep medicine fellowship.
So, why is sleep so important?
Yeah, I mean, there's like I can talk hours on this, but you know,
Sorry, I'm sorry.
yeah. But sleep is one of these things that um it like an easy way to understand this is when we sleep, we are basically allowing our physiologic housekeeping to happen.
Hmm.
And if we
Yeah,
think about this idea of like why is housekeeping so important for any like structure or any home, you can see the manifestation of the lack of housekeeping in the form of like mess, distress, things falling apart.
right.
And in its very like sort of basic form, uh, if we don't sleep well, we will get sick. It's just like it's as simple as that. We can go into the details of this, but sleep is super important for our body's housekeeping to happen in all organ systems, the brain, the heart, the GI tract, the liver, the muscles, the metabolic, the endocrine, everything.
Mm-hmm.
And without it, we just cannot function optimally.
Is okay, so true or false? Do some people need more sleep than others?
That's true.
Okay.
And I will also add to that that day-to-day sleep requirement is also dynamic. Like for example, like if you went to the beach today and you spent an extensive amount of time surfing or you had a lot of expenditure of like physiologic expenditure, a
Mm-hmm.
lot of stress, you might need to sleep more that coming night as compared to your usual baseline. So not only are different people have different sleep requirements, but that sleep requirement is uh, somewhat dynamic on a day-to-day basis.
Right. And I just want to tell our listeners how we came into contact with you. We were looking for someone to kind of help us with the problem of sleep in our practice. And I reached out to Dr. Viglione, who referred me to you. And at the same time, Duncan Turner was having problems with his sleep, with sleep apnea. And we're going to go into his journey with you and Empower Sleep. And
Well, of course,
But-
10 years ago, I didn't think I had a sleep problem. I went to bed, I slept, I got up, and occasionally I might snore, and Karen would get disturbed by it, but I didn't think I had a problem. She told me the problem. I think that happens
Yeah.
a lot.
Yes.
Because I thought I was sleeping fine.
And I do think it is up to the other person to tell the person they have a problem. I mean, you must see
Nicely.
that. I mean, yeah. Well, I said it nicely.
It's okay.
Yeah.
But
No, totally. Sorry, go ahead.
well, so I want to touch on Turner's issues with sleep. You already mentioned sleep apnea, but I also want to talk about menopausal women. So
Okay. So,
So
all right,
you
we'll
go
do both.
first.
Okay,
Yeah.
I'll go first. So, as I say, I didn't think I had a problem. 10 years ago, decided to have a sleep study done. And, that was a time, in huge contrast to what you're offering. You go into basically a 2-bed hotel room, and some person straps electrodes all over your head and all over your body. And then you've got to try to get to sleep. And you hardly sleep at all during that time. You get a few winks. And then in the morning, they take everything off you. You get a report a few days later, and you have severe sleep apnea, and they're making recommendation to you. But it's awkward. It takes time. As you said, it takes time to get the appointment to do that.
and get the result,
And then get the results.
and then get another appointment to go over the result,
Yeah, that's
and then
true.
get another appointment to.
And so, anyway, I ended up not liking the idea of a mask at all. My dentist said to me, well, there are these devices, oral devices that you can take, and they work pretty well most of the time. So I tried that. And it did definitely help with the snoring. But also snoring was affected by level of alcohol. That made a difference. And so I used the oral device intermittently and didn't think anything was getting any worse. And then I started experiencing some pretty radical dreams, some severe dreams that were intense, and I was moving and in fact getting out of bed. And I think I said to you in one of our earlier conversations, we were in Africa on safari and sleeping in the middle of the night. And then suddenly I wake up and I find myself at the end of the 4-poster bed on the floor, having hit my shoulder on the way out. And I know what was happening. I was playing rugby in my dream, catching a rugby ball. I dived to catch it, and I ended up on the floor.
I thought an elephant came through our
It was,
little
but
tent.
a number of these happened, and they were all sort of aggressive dreams. And first thought is, okay, now I've got Parkinson's. That's the end. I'm done. But when we got back, I got tested again. Took a long time to do this. I think I used the mouth guard when I had the sleep study the second time, and it was bad. I had something like
87.
87 occasions of lowering oxygen. And it was just, there was less than 5 minutes in the office of the pulmonologist. You need a CPAP. Here you go. And so I did that. I had also previously tried an Aura Ring, and using the Apple Watch, and neither of those were very consistent in terms of what they were
You sent the
telling
Aura
us.
Ring back.
I sent the Aura Ring back. That's right.
That's how
right.
unimpressed he was with the Aura Ring.
But then I really wanted to have somebody on the podcast because my journey was not a good one. It wasn't enjoyable. And then Alan Viglione put us in touch with you, and we had a conversation, kind of like we're doing right now. And I wanted somebody on the podcast to talk about it. So then, I read about Empower Sleep. I talked to you, understood the mission. I signed up right away. And I was so impressed. I mean, first of all, it was home testing. The second sleep study I did was at home. Okay. What didn't go back to that same hotel room 10 years ago. But what you offer is high-tech, convenient, available, affordable, personalized, and you work with primary docs if that's of benefit in a certain case. So this took this out of the dark ages, as far as I could describe it, into fully using up-to-date technology, state-of-the-art technology, and then being able to talk to somebody. And what you basically did, you gave me a week-long trial, or maybe it was even 2 weeks, of this device that I had on my finger, like an Oura Ring, but it recorded more consistently. And, I mean, this happened within 24, 48 hours. I had that available to test. So much different from my experience in the normal medical patient world, which I was probably getting quicker appointments that way anyway, because I'm a physician and knew the people I was talking to. But so that experience and since has been, I mean, I cannot speak any more highly of your organization. Everybody's great. It's clear. It's just so convenient. It's not expensive. It's just phenomenal. Now, but if we go to that study, those type of studies, what are you looking at other than lowering of blood oxygen? And would you mind going through a sort of basic 101 regarding stages of sleep for some of our viewers and myself? So.
Yeah, no, first of all, thank you. Thanks for letting us take care of you. The whole team is very mission centric of helping as many people as we can and serving as many primary care doctors as we possibly can. And it's been a journey, and it requires a village to build something that can serve more people. And luckily, we have a phenomenal team of practitioners, engineers, operators, designers, the whole gamut. So it's been a process and a labor of love,
Yeah.
as you probably imagine. And like the journey that you described is like so common. I hear this at least a couple times a day.
Yeah.
And when we talk about like, and I'll sort of like fast forward to talking about the stages of sleep here, there's fundamentally two stages of sleep. Or three is probably a better way to put it. You have wake. Wake still falls into the stages of sleep because we have to measure wakefulness during the middle of the night. So you have wake, you have REM sleep, rapid eye movement sleep, and non-REM sleep, non-rapid eye movement sleep. REM sleep is synonymous with dream sleep. Non-REM sleep is synonymous with non-dream sleep, and both are important. If we look at Sleep 101, REM does not have any stages. Non-REM sleep does have stages, stage 1, 2, and 3. And if we look at sleep architecture over the course of the night, typically there is more dream sleep in the latter part of the night, and there is more non-REM or non-dream sleep in the earlier part of the night. And typically one goes through cycles of sleep. They're awake, they go to stage 1, 2, 3, go into REM, brief awakening, stage 1, 2, 3, and these cycles are anywhere between 90 to 120 minutes long. And one will go through a couple of these cycles over the course of the night until they wake up the next day. And it's important for us to have all the cycles of sleep. It's like one stage is not more important than the other. It is important for sleep to be balanced and for it to be as physiologic as possible for that person's given age.
Okay. So what are the things that you're looking at in the study? And that are you also suggesting? I mean, I only got to know you a couple of months ago, and have been doing that, sort of tried a couple of masks. One was better than the other. It didn't seem like much was happening. No, not much improvement was happening initially. We tried some medications as well, and I want to go into some medication later on. But I can't. I don't know how to read the report that is back. I'm not, obviously that's why we're able to speak to a provider. But it didn't seem to bear initially any context to what I experienced. Like it said I was on the CPAP for an hour and a half. Well, I was on it all night. But then at other times when I wake up and the CPAP was elsewhere, it's just gone, and so, and I really could not appreciate any changes in the depth of my sleep or the type of my sleep, that I felt better or anything. I felt good pretty much all the time. But definitely with some time, the count of episodes diminished significantly and gone from a severe issue to a mild to moderate, which was really what I was trying to achieve all along. And also really dealing with the aggressive dreams.
Yeah. So sorry. Yeah. When we look at a sleep study, what we're actually measuring is what is happening to someone's physiology during this window of sleep.
Yeah.
And so sleep architecture is one component of this. The other components of this are heart rate, what's happening to heart rate, what's happening to respiratory rate, what's happening to any pauses in breathing. We're also measuring, does somebody have a lot of awakenings, brief arousals in the middle of the night? And if so, what stage of sleep are they in? What are they triggered by? We're also measuring like movement during sleep. So what you were describing earlier, it's a condition called REM sleep behavior disorder, where there is movement during REM sleep. Normally during REM sleep, our body should be paralyzed, but if it's moving during REM sleep, something could be abnormal. And a sleep study allows us to measure all of these things.
Yeah.
And like in your situation, there was significant pauses in breathing that fit a condition called sleep apnea. And with pauses in breathing, there are drops in oxygen saturation. And when we try to treat the problem or the condition, we're trying to make breathing as normal as possible for that individual in in those circumstances that they're in.
Okay. And do you just gradually see an improvement and then presumably get to a optimal for that individual as good as it can be? And is there do patients continue on this for a while, or do they on the observation? Do they do it every night of the week and every day of the year? Or it would seem to me that isn't really necessary, but maybe it is. So,
Yeah, no, absolutely. Like usually, so like when you probably observe this too, right? Like when you're seeing patients in your clinic, you start something, it takes a little bit of time for that person to respond to that treatment.
Yeah.
And similarly, that's true in the management of any sleep disorder. So patients will typically get better over a period of weeks to months. Some people faster, some people slower. And what I typically tell patients is that this is like a 3 to 6 month journey, depending on what is going on, to take you from sort of bad sleep to substantially better sleep. And also like not just objective sleep, but also we want people to feel better too.
Yeah. Right.
But it does take a little bit of time.
Okay.
That's correct.
All right. Um, when we talk about treatments, is there anything else but CPAP for the sleep apnea? Is that just the gold standard of treatment, or what about? I've seen what's called Inspire, um, and that's a sort of an oral device, I suppose. But can you explain it?
Yeah, no, absolutely. So let me
I
just
don't know
answer
much
your
about
first
it.
question. There are many treatments for sleep apnea.
Mm-hmm.
And the way that we try to explain this to patients is that there are like prescriptive solutions,
Mm-hmm.
like CPAP machines or dental appliances that bring the jaw forward, or Inspire, which is a hypoglossal nerve stimulator. It's kind of like a pacemaker, except for the tongue.
Mm-hmm.
The way Inspire works is that it has a sensing lead near the interthoracic muscles, and when someone inhales, it stimulates the hypoglossal nerve and tongue to move it sort of forward to get it out of the way if there's any upper airway
Okay.
obstruction that could happen. So Inspire is a modality. There are other tongue stimulation devices that exist. There are there's a device called INAP. It stands for intermittent negative airway pressure.
Mm-hmm.
It's like a little mouthpiece that you put in that is connected to like a suction device, and it kind of sucks the tongue a little bit forward to create space in the back of the throat.
Mm-hmm.
So there's a lot of like prescriptive solutions available, but then there's a whole bunch of non-prescriptive solutions available too. Would that range from, sleeping on your side to a little bit of incline to abstaining from alcohol to nasal strips and mouth tape and tongue exercises.
Mm-hmm.
And it just depends on the severity of symptoms that that person has, the severity of apnea that that individual has. And I forgot to mention there's also surgical interventions where it's kind of like a double jaw surgery. Like
Mm-hmm.
one can break the jaw, pull it forward, and that could be very effective. Or if there's a blockage in the nasal passages, like a deviated nasal septum,
Mm-hmm.
fixing that or reducing the sizes of the turbinates. So the way that we think of this is sort of in stages. Like,
Mm-hmm.
what do we need to do now to solve the problem? But there's actually quite a few like definitive solutions that are available too that can actually liberate someone uh, from CPAP. And in fact, uh, there was a really nice trial looking at tirzepatide, essentially
Yeah.
curing people of sleep apnea if
Mm-hmm.
obesity was the driver. So
Right.
it's kind of like figuring out what's the driver of the problem,
Mm-hmm.
how bad is the problem, and then coming up with a plan that is personalized to that individual, and tracking how well they respond to that solution, like how effective is that solution.
Yeah.
And over a period of a few months, you can get someone from where they were to a much better place.
Right.
Well, is trazepatide, does that work because it makes people lose weight, or is there some other mechanism?
Yeah, it's the same mechanism as like bariatric surgery would be
Okay.
for curing sleep apnea. So it's
Mm-hmm.
actually the mitigation of apnea is a byproduct of weight loss, not a byproduct of any sort of receptor in the upper airway. It's not changing the pharyngeal tone as far as we know.
Okay.
It's mostly weight loss
Yeah.
that is driving the reduction of apnea.
Right. So I've monopolized this. Go ahead with your
Oh,
menopause
yeah, I
question.
want to talk about menopausal women and how you would treat a menopausal woman that comes to your Empower Sleep Clinic.
Yeah, thanks for the question. I think it depends. Like like in medicine, so many, like as a physician, so many things depend on certain factors, and
Of
I
course, like
hate,
what medication they're on and things like
yeah,
that. Yeah.
but generally speaking, we would still start off everybody with a sleep study
Hmm.
just to get a sense of like what's the overall health of their sleep. And one sort of thing to note is when one transitions from a sort of reproductive physiology to a non-reproductive physiology. Um, in the absence of estrogen and progesterone, like a few other things also happen that are specific to sleep medicine. There's almost a doubling in the prevalence of sleep apnea. We think estrogen and progesterone might play a role in upper airway tone. There's an increase in prevalence of restless leg syndrome, like this restlessness in your legs that happen. And that combined, and the other thing that also happens is we think, or we've observed, that there is a reduction in the arousal threshold that happens when one is transitioning from reproductive physiology to a non-reproductive physiology. And think of the arousal threshold as like kids have a very high arousal threshold. There has to be a lot of noise and movement to wake them up out of sleep. But when one is transitioning from perimenopause to postmenopause, that threshold kind of drops. And so sleep becomes more fragile. There is an increase in the prevalence of sleep disorders like sleep apnea and restless legs, in addition to like these vasomotor symptoms that they may be experiencing. So like the way that we try to address this is to identify what sleep conditions are at play. Let's address those independent of whatever they may need from like an HRT standpoint. So I think it's like doing two things in parallel versus just assuming that the reduction in sleep quality is because of the absence of
Estrogen.
reproductive hormones. Yeah.
Right.
Do you see that, or when patients are treated with hormones, do you see their sleep get better? Have you noticed that?
Yeah. We're lucky because we get to track data over time. And I have seen a couple of people, and it's remarkable. Like their sleep quality increased substantially just by the addition of hormone replacement therapy.
Yeah.
It's not always the case, but it does happen often enough. And it can be pretty exciting to see that.
Well, I can, certainly with the experience I've had with you guys, as recommend to patients, because now they're not going to wait for the month or two to get the sleep study, and nobody really wants to do those sleep studies that are taking all night and somebody watching over you one way or another. I mean, it was even the at-home one with the hat on my head, and
that was ridiculous.
We had a bit of a fight over that one.
That whole thing was just so funny.
Right. Yeah. So, yeah, I see this. I mean, my practice is mainly menopausal medicine now, and the clue often to the perimenopausal time were women having difficulty sleeping. Or that was the sometimes the only symptom that they were having, with a essentially lower estrogen level. But now, I mean, being able to refer these patients to you, and a test is on the end of a phone. It's just brilliant. So thank you.
Do you lead most of the time with like lifestyle changes or medication, or a combination of both, depending on?
Yeah, Karen, it kind of depends on what's going on, and like how much like suffering one has. And so we're very open. I think I kind of let the physiology tell the story. And like if we have a patient who wants to try behavioral and supplements and lifestyle modifications, I just usually tell them, hey, we can do this for a month. Let's test on a nightly basis. Please just journal it in the app.
Yeah.
And let's see if it moves the needle. If it does, that's amazing. That like problem solved without the requirement of any kind of like prescriptive intervention.
Yeah.
But if it doesn't, like, guess what? We're still here to help you to get to a solution that from a medical or an evidence-based standpoint, we know can work reasonably well. So it kind of depends on the patient, how they're thinking, what their goals are, but like we're pretty open.
Yeah, if somebody is just devastated, you're probably going to want them to get some sleep.
Totally, 100%.
And
And in fact, sorry, just to add, if we needed to prescribe somebody a sedative or a hypnotic for, say, a week to help them like sleep somewhat better through the night, and then be able to make a more thoughtful decision 7 to 10 days out, that's okay too. Like
Yeah.
we can totally do that because when someone's sleep is better, they have more emotional resilience, they have more thought clarity, they can just make better choices.
so I have a question, just this is my own experience, because sometimes I just don't sleep for nights on end. And if I take something, that messes me up more because then my body requires that to sleep, whether it's a short acting sleeping pill, what is it? The one,
Restaurant.
Restorol, or if I take like something to relax me. This is if I'm exhausted, like to the point where, oh my God, I just have to break the cycle. But then, how do you, because if your body just so quickly gets used to that, and you must deal with this with patients, that they can't take anything because then they can't get off that thing to sleep on their own.
I think a better question, at least what I'm thinking, is why does one have these cycles? Like
Yeah.
what do we think is like the root cause of these cycles? Is it anxiety? Is it like some other condition that is cycling that is triggering this? Like what do you think?
A lot of the time it's the moon for me.
Mm-hmm.
But I know some people have anxiety or they're worried about something, and I am too sometimes, but it seems to like a full moon cycle will make me just more wired and alert and awake. Like where just feel in my body, I am so far from sleep. I'm so far away from it. I might as well just get up and do
And
something.
it's not always a matter of getting to sleep. With Karen, I mean, she will on times just be in the trying for hours and not being able to get to sleep. But other times she will go to sleep and then wake up 2 hours later.
2 hours later, like I had a nap,
Like how long has this been going on?
like forever.
For decades?
Yes.
Okay.
Yeah.
Um,
Do you want to give one
But-
other clue there
but-
in terms of other medical reasons?
No, I don't. I mean, I don't like have medical reasons. I don't think why I'm not sleeping. It's mainly my mind and like overactive mind, like where I'm constantly thinking and working, or I'll think, oh, I need to get this done. I'm going to get up and do this now because it's quiet. Or sometimes it's just me. But if I take something to break the cycle, then I'm like,
You feel you cheated.
then I have to stay up a couple nights to then fall asleep out of exhaustion.
Yeah.
To-
One thing that I'm just like curious about is there's a condition called a non-24 sleep-wake disorder. It's basically when you said moons, like that makes me think of like something happening like prolonged like cycles. And in this circadian rhythm condition, basically one's body clock shifts a little bit every single day.
Mhm.
Forward usually. Usually it moves forward every single day, and like over a period of many weeks, one sort of like their body clock kind of resets back to what is sort of like their what is a time that matches with outside darkness and daylight. So if this has been going on for decades, I think like a really easy thing to do would be to do what's called a melatonin profile, where it's a salivary test where where we can measure over a 24-hour period when does Karen make what is Karen's biologic night? What is her nighttime? From what time to what time? And it can be measured indirectly through melatonin that is in the saliva.
Oh, wow.
Melatonin only rises during the hours of
Mhm.
darkness, during the body's nighttime. And so like if your body's nighttime is shifting every, let's say right
Day.
now, I'm just throwing out numbers.
The
It is
full moon is Thursday. So I'm really
like
aware
for
of it.
example, again, like I'm just thinking of this, like I don't know how the moon influences these things,
Mhm.
but just from a circadian standpoint,
Yeah.
like let's say right now your nighttime is like midnight to 8 a.m. and we do this again 2 weeks later, and your body's nighttime is, I don't know,
9 p.m.
5 a.m. 5 a.m. to sort of 2 p.m. Like that will be a clue that you have this sort of rolling circadian rhythm that is just sort of coming back to square one every, 20 some odd to 30 some odd days. And that might be something worth investigating
Yeah.
because it could be anxiety. All of these things I think are diagnoses of exclusion, but it's my responsibility to do the appropriate workup to
Hmm.
see like what could be going on.
Yeah.
Because if we do identify something, like at least we can then come up with a solution.
Yeah, I mean, because it's pretty remarkable because sometimes I sleep so well and it's days on end. I'll go to bed like at 9:30 at night. I'll fall right to sleep. I'll sleep a full 7 hours. That's awesome for me. Tons of energy. I wake up, I am ready to go. And then other times where it's like midnight and I'm so far away from sleep, so far. Like I'll go to bed, like I'll get back into bed like at 4 in the morning
Yeah.
and sleep
The
till
other
like 7.
Yeah, the other thing that can be done is to get more clarity on this is to do actigraphy. That's basically a graph of activity. It's like a watch. You put this on, the battery life is like 60 days or so, depending on the model. And you basically put it on, and one can measure remotely, like what is Karen
I'm
doing?
laughing because I don't ever stop. You're gonna be like, oh my God,
She's still asleep,
that's gonna be embarrassing if
still
we do
awake.
that.
But the point I'm trying to make is, there's a lot of tools available that I think
Yeah.
just we don't know exist,
I
but
had no idea these two things existed, but I'm definitely gonna do them.
Yeah. The other thing that she didn't mention, she has MS and she's on medication for that. She's,
But that doesn't affect my sleep.
well, I'm asking the expert. That's
Well,
all.
I don't feel it affects my sleep.
I know you don't.
Yeah. But
I don't either.
it's a possibility because, the regulation of circadian rhythms come from the brain,
mhm.
specifically from the suprachiasmatic nucleus, which is sort of like the pacemaker for
Yeah.
circadian rhythms in the brain, and that tells like the pineal gland, which is in the back of the brain, to make this hormone called that we all call melatonin.
Hmm.
So if there is like a lesion or something, um, could it alter circadian rhythms? I think it's very possible.
Mhm.
But but again, we're just sort of like hypothesizing here. But it is a possibility. It definitely is a possibility.
Yeah. All right. So I'll be in touch regarding those tests because I think it would be interesting. They both sound really
Yeah,
interesting.
absolutely.
Yeah. So on the activity test, do you just look at all the activity and then say, all right, you need to calm down at a certain point?
Yeah, it's a couple of things. It's activity. The second thing is it has a little sensor that measures light. Like how much lux exposure are you exposing yourself to?
Okay.
So it also tells you like what wavelength of light and how much light one is exposing themselves to. And because our circadian rhythms are controlled by light and darkness, we can start to get a sense of like how much of one's sort of absence of activity or, quote unquote sleep or activity is like what is actually happening over a 30 or 60-day window, because many times it's when we ask people to sort of think back and remember what is your sleep timing like, usually there's a big delta between what the patients actually tell us and what we actually find.
Yeah.
And
I could see that even just by looking at his, Duncan's.
yeah,
Um, and I want to go over that too. So just briefly or just describe the patient experience, like when they start with you guys. How does that look?
So usually we'll meet with the patient for about an hour, hour and a half to understand from like a very holistic healthcare standpoint from sleep, medications, surgeries, behaviors, thoughts, caffeine, exercise, their sleep environment, what all is going on that could be contributing them to feeling the way that they're feeling. We'll then mail them a home sleep testing device. We have a few different ones, but this is the most like basic program that we have where we mail this ring to the patient. It's a FDA cleared medical diagnostic. And instead of using this as a one night sleep study, which most, there's probably 1,000 clinics in the country using this kind of a test, but they're still using it in a one night, 2 night study. We tell the patient, hey, keep this for 7 to 14 days. Let's establish a baseline of your sleep health. And during this 7 to 14 days or 3 weeks, whatever the patient needs, let's um, please journal. We can do some experiments of like what you think is helping you, what you think is not. And then let's reconvene to review the data. When we review the data, that's like another 30 to 40-minute visit where we then come up with a plan. We make a diagnosis of like what's wrong, what are some of the abnormalities, and then what will be the strategy for the next 3 to 6 months to help them solve that problem. And now we've taken care of thousands of people but by looking at 2 to 3 weeks of data, we can say with a pretty high level of conviction of what we think is going to play out over a period of time to get them to better sleep even faster than we did a year and a half ago.
So
And during this journey, we meet with the patients every 2 to 3 weeks. All of these visits are on Zoom. They're through telemedicine. So the patient gets to stay in the comfort of their home. They get to do sleep testing on an ongoing basis in the comfort of their home. And our entire clinical team is remote too, so they get to work from home too.
And if somebody is working with you and let's say they get their sleep under control, and then let's just say they're going through a rough time again, do you see what's happening again? Do you look at their sleep again?
It's a good question. We do, because if you don't look, you won't know what's going on.
Yeah.
And so we typically do.
Okay.
And sleep, just like our physiology changes with age, it's not uncommon for people's sleep to change over time or sleep to change with a new illness. Like, for example, I just saw a patient recently established care with us maybe a year and a half ago, and then a few months ago developed AFib and atrial fibrillation, some cardiac dysfunction, and sleep and breathing changed. And like he was already on CPAP, now he required the CPAP machine settings to change. So I would not have known that if I had not done a repeat sleep study. So we tell patients, hey, keep the ring. Let's just, test intermittently. You don't need, once sort of one is stabilized and is sort of in a maintenance phase, they can test whenever they want to.
Oh,
But
that's good.
Go ahead.
Relative to that,
I just said that's good that they can. Yeah, you can relook at it. Yeah.
Relative to that, how often are people in touch with you over the course of a month or two? Once if you're on a pathway and everything is going pretty well, continues to improve, there's no sort of big peaks and valleys at that point. Do you still? I mean, if I do a study, somebody there is going to see it, and somebody's going to respond.
Correct.
Right.
Correct.
Okay. And so doing it intermittently can be helpful, and maybe doing it every night is not necessary.
That's correct.
Okay. So that was, you actually answered that question in that discussion then. What about with this, Karen, getting on to having a sleep study? Would that be high on the list for her?
Yes, I need a sleep study.
Yeah,
For
I
a
would.
full cycle of the moon. We're going for the full moon cycle.
Can you put one in the mail now, please, for her?
Yeah,
We
no,
got a
let me
couple of days.
let me slack the team and we'll get you guys another ring
Yeah.
shipped out.
I mean, what's funny is when the night of the full moon happens, I actually sleep it's just until the night of the full moon, the week before the full moon. But then once that moon is bright and full, I actually sleep that night. It's
Interesting. And
really weird.
this has been going on since when?
For like as long as I can remember, even as a kid.
And then
Yeah.
with Karen, there's another dilemma that comes around daylight saving time. So that
Messes me up
that messes her
totally.
up completely.
Yeah. It's just an hour, but it's just so much for me. I'm exhausted and my sleep's off and yeah.
But I think that melatonin test and seeing what Karen's cycles are is just
Yeah.
really
I mean,
breakthrough.
because sometimes I love getting up in the middle of the night. I get so much done. I'll work for like 4 or 5 hours. I'll be more productive in that time than I would be in a 2-day work
Wow.
period.
Yeah.
You know what I mean? I'm super alert. Yeah.
Yeah, I would like to do an actigraphy for you as well as a melatonin profile as well as a sleep study and like sort of track this over a couple of months to see what we find. And I'll do some homework on this too about like how like in like yogic and Indian literature, I'm sure there's something there between the moon's gravitational forces and influencing our physiology in some capacity. I don't know anything about it, but I'll do some homework on this too,
Yeah.
so that we can have an educated conversation about this.
Yeah. I mean, I think I just kind of figured it out one day. Like, wait a minute. It's always around the full moon that I get like this. So I don't know if that's it, but I'm thinking it is. That's my own diagnosis for myself.
And she's
Yeah,
sticking to it.
we'll figure this out. We'll figure it out.
Good. I'm excited.
So, Sahil, you were in the paperwork that we sent to you. One of the questions was, how would people describe you? And the answer was brilliant. It's Sahil does what he wants to do and is only persuadable by logic. It's brilliant. I'd like to be able to apply that to myself, and I think some of the time I do, but I'm not quite as consistent with that as being only. But what do you do when you have that logic and you know what you're being asked to do is
Not
not
logical.
logical and somebody getting upset with you because you're not doing that way? How do you deal with the frustration that you get when somebody doesn't agree with your logic because they're being illogical?
Yeah, I mean, I'm not perfect. I'm like far from perfect at this, but I think I try to just remind myself that, I guess like one way to think about this is, I ask myself the question, am I willing to just put my ego aside to do something to make someone else happy? And I think if I remind myself that it is my own ego that is getting in the way,
Okay.
it becomes really easy to put this aside and
Mhm.
do what is required at that moment in time.
Yeah.
And
Good answer.
like
Wow.
just
Like it.
get over it.
Get over it. And the fun fact about you love do-it-yourself projects, and you have built a tandoor, or you are going to do it.
No, I did
You
in
did.
fellowship. So for the people that don't know what a tandoor is, it's like a clay oven in which if you go to an Indian restaurant,
Mhm.
they give you this bread called naan.
Oh, yeah.
It's like usually very flavorful, tasty, fresh bread made out of made in a clay oven. Other like meats are also cooked in a clay oven because it reaches temperatures north of like 700-800 degrees Fahrenheit, and it's a really traditional way of like cooking Indian foods, specifically bread and meat. And when I was in fellowship, and like you were when you were in residency, you don't have any money.
Mhm.
And I saw this like DIY video on YouTube of a guy who had taken a terracotta pot,
Mhm.
those little clay
Mhm.
terracotta pots,
Yeah.
connected two of them, and sliced off the top of one to create like a sort of a cylinder,
Mhm.
um, wrapped it up in insulation, and put it in a trash can to create like an artificial sort of DIY tandoor. And I just thought it was brilliant. So I took that and ran with it, but put some bricks on the bottom, put some bricks on the side, but use that as like a skeleton of
Uh-huh.
uh, building a tandoor in the backyard, which was a lot of fun.
Great.
And, I think it just like stimulates a little bit of creativity, a little bit
Yeah.
of critical thinking, and trying to build things out of like limited resources,
Yeah.
and time, and just having some fun with it.
The attraction for me is actually just the food. The food that comes with
I
it.
do.
I went to medical school at the University of London, and the staple diet for the English medical student, probably all students, but particularly medical students, it seemed, is the curry house down the road. Indian restaurants. So it's always been close for me from the time I lived in the Caribbean when I was a kid, and then in London and medical school. So the clay oven was really interesting. So thanks for that info too.
When I come over to visit you,
Uh-huh.
Duncan, I'll build one for you.
Oh,
We'll make a trip down to Home Depot or Lowe's,
Okay.
and we'll put one together.
oh my God,
Fantastic.
that would be great. Ooh, and then you can cook in it.
Yeah.
I like
exactly.
that.
Mhm.
Okay, we touched on medication, but I know our listeners are going to want to know a little bit
Yeah.
about medication. So we hear a lot about melatonin. And what's the new one out that our longevity people talked about for sleep? Um, the new, I guess it's more like a supplement people are taking for sleep.
There's like L-theanine, ashwagandha,
That one,
glycine. Huh?
ashwagandha. Is that what
Yeah,
that one? Lysine.
a couple.
Yeah.
Yeah, there's a couple.
And then there's sleep aids. Where do you sit with those supplement types or the others? Like, give me your opinion on all those.
Yeah, so again, this is like opinion, not data. I'll
Yeah.
share data and then I'll share my opinion. Data suggests that these things could possibly help. Okay. It's a little bit heterogeneous, but it could possibly help. Um, we have like a very strong selection bias of people that we take care of.
Yeah.
Most of the people that come to us have like clear pathology and significant disease. And I have yet to see a supplement move the needle to improve the physiology of someone's sleep. That doesn't mean that it does not happen. I just have not seen it for the thousands of people that we've taken care of.
Mm-hmm.
And this is again with the caveat that there is a selection bias here. Um,
Mhm.
but I do think that these things could help the right individual. And usually for supplements, it's if we correct the deficiency, the supplement will be effective. But if there is no deficiency and giving someone a super physiologic dose of something, whether or not it's effective or not, I think that's still kind of an open question. I
Right.
don't know what your guys' thoughts are of the
Well, I
use
mean,
of.
it's always been interesting to me, the whole supplement thing, or, it's all over Instagram right now. Oh, I just take magnesium. Take magnesium before you go to bed and you're just going to sleep like a baby. I have friends that tell me the same thing. That doesn't work for me. I've tried melatonin. That doesn't work either. So in terms of like a go-to sleep aid, do you have a go-to sleep aid for people that actually need the aid, the real aid, not
Do
just
you
a
mean a
supplement?
prescription?
Yeah, prescription.
Okay.
You mean like a prescription medication
Yeah.
for insomnia? Is that what you're asking?
Yeah,
Like a
yeah. If
prescription?
somebody's if they need sleep right away.
Yeah, I typically, again, it kind of depends, but if someone, it depends if it's an acute problem or a chronic problem.
Right,
Mhm.
Okay. Now, if someone has chronic sleep onset or sleep maintenance insomnia, the question becomes like, why is that the case?
right,
And I try not to blindly reflexly prescribe anybody anything, and I will still start off with like a sleep study
right.
to understand their sleep health and architecture and timings and duration and quality. and then come up with a plan. And, use like what is recommended again from the guidelines is cognitive behavioral therapy for insomnia, CBTI.
Yeah.
Jumping to a sedative or a hypnotic is not the recommended solution in the absence of doing CBTI in a chronic insomnia type of condition. But that's very different than acute insomnia where someone is going through a breakup, there's a death in the family, there's a big stressor in life, or there is jet lag, or there is something
Yeah.
acute that has some reversible component to it.
Right. Yeah.
That I think is different. Like that one can approach that with a sedative or a hypnotic,
Yeah.
with some kind of an exit strategy that we're only going to do this for 2 weeks or 3 weeks or a week. This is not something that we're going to do in depth, like prescribe and forget about it.
Mm-hmm.
And in those situations, um, depending on what the driver is, there's a whole host of medications ranging from the Ambiens and the Lunestas of the world to trazodone and doxepin. And then there's some over-the-counter solutions as well. So I think the way that we choose a drug is based on what are some of the comorbid conditions that they may have.
Right.
If they have sort of like anxiety or headache and insomnia, then one might choose like amitriptyline as a medication. If they have chronic pain, restless leg disorder, then we might choose something like gabapentin or pregabalin as a choice.
Mm-hmm.
So it kind of depends
Yeah,
on like what else
that's
is in
good.
the
Yeah.
background,
Mm-hmm.
and then that's how we come up with a plan.
But everything starts with a sleep study.
Yeah, for us it does.
Yeah. I think that's great.
Yeah, yeah. I'm like the way the analogy that I try to give to patients is, or anybody really, is when you go to your primary care and you tell them that you have knee pain, it wouldn't be very intelligent for them to just prescribe you like a narcotic or a pain medication.
Mhm.
Like an intelligent thing to do is like, let me examine your knee, let me check range of motion,
Mm-hmm.
let me do an X-ray, and then let's get this done right now, and then let's come up with a plan in like an hour from now after we get some imaging. Similarly, we try to approach sleep with that thoughtful nature of let's get some objective data, let's get a good history, let's understand what's going on, and then come up with a plan.
And that's what you've made so easy with us.
Yeah.
I mean, it just is brilliant. It's a
Yeah.
phone call and a consult as you're describing, and at least some information right away. It's great. Good job. Good job.
Thank you, Duncan. It's been a journey and it's been a lot of fun.
Thanks. Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.